I think one of the most devastating complication of ERCP is a post-ERCP pancreatitis. And attention to this was brought by Marty Freeman in this very famous landmark article where we knew that 9% of patients, wherever ERCP is done, develop pancreatitis. Global surveys over several years have shown that about 10% of average risk patient and about 14% of high-risk patients in general develop post-ERCP pancreatitis. Over the last few years, there's been great advances in knowledge of understanding the pathophysiology of post-ERCP pancreatitis and also in trying to prevent it. So can we achieve a zero post-ERCP pancreatitis? I'll tell you the answer at the end of the lecture, but I'd like to discuss in the 5 Ps of post-ERCP pancreatitis. Pathophysiology of post-ERCP pancreatitis is well understood here, and this sort of synopsis of the different causes for this. It could be hydrostatic pressure because of contrast, thermal injury, infection, and so on, all resulting in the first hit, which is trypsinogen activation. The second hit, of course, is cytokines that can cause the generalized features of post-ERCP pancreatitis that we see. One of the reasons we thought was an important cause for post-ERCP pancreatitis was contrast filling the pancreatic duct. And this is often cited from this famous article as if you fill the pancreatic duct, you get most post-ERCP pancreatitis. But we realized that more important than contrast is actually the pancreatic guide wire insertion. Pancreatic guide wire insertion is more likely to result in problems of post-ERCP pancreatitis. And this very important study showed that compared to the actually contrast, it was a guide wire insertion which more often resulted in pancreatitis. And this is an important knowledge because this has resulted in our changing the plan of what we do in these patients. If you pass a guide wire in an average patients more than 3 times, or in a high-risk patient more than 1 time, you have to put a pancreatic stent. And this message is very clear to prevent post-ERCP pancreatitis. Can we predict post-ERCP pancreatitis? I think here we know all the old prediction that has been done, patient-related, technique-related, and so on. But we're getting better now. We know that actually you can calculate the exact incidence of post-ERCP pancreatitis. In fact, if you, for example, have a young woman with normal bilirubin, non-dilated ducts, is a 40% chance of developing post-ERCP pancreatitis. So you know whom to avoid to do an ERCP because this would be a definite occasion for that. There are 2 other interesting new predictors that I've come up with, and one is pancreatic steatosis. This study clearly showed if your CT scan before the ERCP shows that this patient has a pancreatic steatosis, the chance of developing post-ERCP pancreatitis is extremely high. So therefore, when our radiologists report that this pancreas is having a fatty pancreas, we are very careful about how we handle this patient. The second important predictor came from this renalase levels. Renalase is a flavoprotein secreted by the kidney. It is an anti-inflammatory effect, and it has been clearly shown that high renalase levels can be protective for patients with. So we are now doing a study in our unit where we are looking at renalase versus post-ERCP pancreatitis, and it's very clear that with the high sensitivity, actually you can predict which patient is likely to develop post-ERCP pancreatitis based on the renalase level. Specificity is low, but sensitivity is extremely high. So this is another thing that's going to help us. Of course, with artificial intelligence, machine learning, you know that there are certain parameters which suggest post-ERCP pancreatitis. And we have recently published this where we have actually a pocket calculator based on machine learning, a point-of-care high-risk prediction can be done in these patients based upon variety of parameters. You just feed this into your iPhone, and just before you do starting your ERCP, do this, and you know how careful you have to be with this particular patient because the chance of ERCP, post-ERCP pancreatitis is going to be extremely high. So can we, using all this knowledge, actually prevent post-ERCP pancreatitis? To some extent, we now know that using prophylactic stents, rectal NSAIDs, perioperative fluids, or a combination of this, you can decrease the incidence of post-ERCP pancreatitis. Of course, this landmark article from Joseph Almanza showed that if you use rectal indomethacin, then you can decrease the incidence of post-ERCP pancreatitis in high-risk cases and also decrease the severity of the pancreatitis without increasing the complication rates. There have been several RCTs now shown the similar effect of reduction. The question now is, should we use NSAIDs for all the patients or only some group of high-risk patients? Again, there have been several guidelines, but in general, the conclusions from all these guidelines are that all the patients, irrespective of whatever you do, even if you're removing or exchanging a biliary stent, it's better to use NSAIDs as a prophylaxis. The question is, what timing should we use? In general, for many years, we have been using this after the ERCP. But this has changed now, and there have been many articles on this. So this is a little complicated article which came from a multicentric Chinese group, and they showed very clearly that using rectal indomethacin 30 minutes before ERCP is ideal. This is what has to be to prevent post-ERCP based upon the kinetics of how indomethacin gets absorbed. So what we do in our unit is that we always have, because the nursing staff forgets, the doctor sometimes forgets, so we have this sticker on our case sheets where indomethacin and the timing of indomethacin are given, because the patient is posted, sometimes the doctor is busy and he can't do this within half an hour, so probably he'll have to repeat indomethacin. So this is what we normally do. In many countries, indomethacin is still not available. It has been shown that diclofenac is as good as indomethacin in preventing post-ERCP pancreatitis. Pancreatic stents are another technique, and you can see from this picture why it's preventive. In fact, the pancreatic and biliary orifices are very close to each other. So when thermal injury occurs, it can occur in the pancreatic orifice, and therefore putting pancreatic stents can be useful. Again, this this is a meta-analysis showing clearly how pancreatic stents are going to be useful. Uniformly, they have been used. And what type of stent to use and which stent to use and so on. This is an RCT from Todd Barron's center, which showed very clearly that if you actually put in 5 French 5 centimeter single pigtail stents without enough flap, this is the best technique to prevent post-ERCP. Shorter stents, smaller stents tend to fall up too early, longer stents stay too long. So this is an ideal combination to use in these patients. And so what happened in real-world practice was in 2012, when Joseph Elminzer article came, people starting using more indomethacin, less pancreatic stents. This was unfortunate because pancreatic stents can be really useful in certain situations, like when you use a double guide wire, when there's PD cannulation of more than once in a high-risk case or more than 3 times in an average risk case, SNRization, and of course the high-risk cases. So this is where PD stents have to be used, and in fact you can see this very clearly. This is a patient whom we could not get into the bile duct. So we put a wire into the pancreatic duct and then cannulated above, and then got very easily into the bile duct. So the question here was, should we just leave this patient alone, which used to be what we used to do early, finish the procedure, take off both the wires. But it's shown clearly that if we use this technique, if we don't put in a prophylactic pancreatic stent, these patients, a high percentage go into post-ERCP pancreatitis. So we now always follow this double guide wire with a pancreatic stent. So what about combination therapy? We know that pancreatic stents protect. We know that indomethacin protect. Can we combine both together? Again, initial studies showed that this may not be helpful. But I think the recent study in Lancet from Joseph Elminzer again shown very clearly that in patients with high risk, a combination of indomethacin with pancreatic stents is superior to only indomethacin in this group. So our suggestion is that in all patients with high risk, be prepared not only with indomethacin but also pancreatic stents to prevent post-ERCP pancreatitis. And of course, now we come to the last area, that is the fluid therapy. Here there's been a lot of controversies, but finally it's now known that giving adequate ringer lactate is helpful in these patients. Why ringer? Maybe ringer actually has got an anti-inflammatory effect, and that's why it's better than normal saline. So ringer lactate given before and during and after ERCP is shown to be protective. Although how much we should give is a little controversial. In this study, in fact, again, showed very clearly that very aggressive fluid therapy may not be additionally beneficial. So we do not actually push very high levels of ringer lactate, especially because some of these patients are old, can go into cardiac failure. But what we have found is that even modest amount of fluids given before, during, and after ERCP, like 3 ml per kg body weight per minute, can be helpful in preventing post-ERCP pancreatitis. So Combining all these factors together, 3 factors, IV fluids, pancreatic stents, and indomethacin together may actually reduce your rates. In our unit now, the rates have been reduced from 9% on average to 2% using all this. So, of course, what are the techniques to prevent post-ERCP pancreatitis? This is, again, very important to follow, because we know from several studies, and this is an Australian study, we showed clearly that if you actually try and manipulate the pancreas papilla more than 9 times, take more than 10 minutes, your chances of post-ERCP pancreatitis is very high. So this is very important to realize that you should not do this when you're manipulating. And of course, we now compared to guide wire cannulation and contrast cannulation, guide wire cannulation is better in preventing post-ERCP pancreatitis, and this has been repeatedly shown. 2 other techniques, very important. We used to think that using pure cautery, pure electrosurgical technique is better than mixed or having a combined technique. Now there's no evidence for this. Using pure or a combined electrocoagulation is similar results. So therefore, we don't have to always think of using pure current, because bleeds are higher with that. And again, very important, using early pre-cut can result in decreased amount of post-ERCP pancreatitis. This is very important, because one should not try for more than 10 minutes to try to cannulate the papilla. You start using early pre-cut. That is very important. And again, probably because of this, consequence of this, you can see that failed ERCP has a higher post-ERCP pancreatitis rate. So if you have a patient in whom ERCP failed, it's better to observe or admit the patient, because they are the ones who are likely to develop more severe post-ERCP pancreatitis. And of course, what are the things that we do? Real world scenario, you see the 4 steps. We always put rectal NSAIDs, start our patients on IV fluids, ringalactate, and then we do guide wire cannulation. We put in a pancreatic stent, especially the multiple cannulation of the pancreatic duct, and we continue the IV fluids after the procedure. This is what is normally done, and this is the technique that we follow in our institution. We usually IV hydrate with 1 pint of ringalactate, routine rectal indomethacin, and in our patients, ringalactate continues during ERCP, pancreatic stent in difficult cases, and post-procedure we give 1 more unit. So it's very easy to remember. You don't have to remember numbers. 1 unit of ringalactate before, 1 during ERCP, and 1 after ERCP. This is sufficient in most cases, and this has resulted in fairly significant decrease in post-ERCP pancreatitis in our unit. Now, participation, this is again important. It's very strange that in spite of all the evidence we have that rectal indomethacin is actually protective against post-ERCP pancreatitis, in many units, even in the United States, the rectal indomethacin is not used. This is, of course, unfortunately, 1, because of lack of knowledge, and secondly, because of the cost. Look at this. In 2012, before the famous Joseph Elmenger study, rectal indomethacin was costing $17. Since then, the price has come up, and now rectal indomethacin costing $340. You can actually do 2 ERCPs in India for this cost. And therefore, what happened is that rectal indomethacin use has not been as universal as we thought. And now finally, let me tell you the secret of how to have zero pancreatitis after ERCP. I'm sure you're all very keen to know this, because those who are doing ERCP should learn this. That is, just don't do it unless it's strongly indicated. Thank you very much.